Well, we are live now.
So thank you. So good morning, everyone. And in this module of pediatric trauma basics, we have today Dr. Andrea Chan from Sickkids Toronto. Welcome, Andrea, and thanks for your time. I'm pretty sure that our fellows and trainees will immensely benefited through your knowledge. Preksha, can you introduce our faculty today?
Yes, sir. Good morning, everybody. It is my pleasure to welcome Dr. Andrea Chen to our module. She completed her orthopedic residency at University of Toronto. She further did her upper extremity fellowship in London, Ontario, and Cleveland, Ohio. She has published numerous scholarly and clinical work. Dr. Chan specializes in the management of full spectrum of upper extremity disorders in children and in adolescents. It is my pleasure to invite you for this talk. Uh, You can share your slides.
Let me, yes.
Thank you so much, Dr. Shah and Preksha, for that introduction. I'm really honored to be here to give this talk. I'm just going to put this in. Can you see the present? Can you see the?
Yeah,
Perfect.
yeah, it is very well seen. Thank you.
Okay, perfect. And so this this interest of mine was really born out of some of my experience, particularly in my pediatric hand fellowship at Cincinnati Children's with Kevin Little and Roger Cornwall. So when we started to look back at some of these patients who are coming back with really terrible radiocapitellar joint arthritis at very young ages. And so this was kind of born out of it. And so I'm going to speak to you about the spectrum of the pediatric trash elbow. And this is um, acronym coined by the Boston group, which really just means that it's an acronym that means the radiographic appearance seemed harmless. And so I'm going to go through a series of cases and then talk a little bit about my experience and augment that with the literature. So thanks for having me. Okay, so I have no disclosures here. And so these are the 5 patients that we'll review today. And so this first patient, he's 11, healthy. He had a fall and outstretched hand while playing basketball, and this resulted in a right elbow injury. So this is patient number 1. Here's our second patient, patient number 2, 12-year-old healthy. This particular patient also had a fall while playing basketball and had a right elbow injury. And so we can see, pretty innocuous x-rays here. This is our third patient, which I'll review. So this is a 6-year-old female. She has type 1 diabetes. She fell on a ball and she had a left elbow injury. And patient 4, very similar to the first 2, another sporting injury of a young teenager, had a fall while playing lacrosse and sustained a left elbow injury. And then our last patient, 14-year-old boy, he fell off his bicycle and sustained this injury. Okay, so these 5 patients are going to highlight this constellation of injuries called trash lesions that are particularly pertaining to the pediatric elbow. And so with all of these, we look back and we say, quick glances, elbow looks aligned. We don't see really much going on. So when we peruse through these very quickly, can we treat this just in a cast and, we've hit our game-winning home run and we can all go home and be happy? Well, we'll review what has happened with some of these patients. So patient number 1, and this is where I really started getting interested in these trash lesions, was referred to us 3 years after his injury following his elbow pain. So now he's 14 years old and he presents with elbow pain, swelling, stiffness, and his range of motion is diminished, 30 degrees to 130. His pronosupination also diminished. No signs of instability, but these are his x-rays. And so, patient number one, we had pretty innocuous x-rays, but he comes a couple years later with this terrible looking radiocapitellar joint. So we can see this very significant arthritis that's formed in the radial head. We see some physeal disturbances medially. We see potentially a kissing lesion on that capitellum, and we see subluxation of the joint itself. So really, this has not been a win, and this was a missed injury. And so when we go back and take a look at his initial x-rays and we start to look with a kind of a retrospective eye, we might be able to see tiny flecks of bone that we may not have noticed earlier. And so one of the very particular flecks of bone I want to bring your attention to is this anterior avulsion off the radial neck and head. So if we blow this up, you can kind of see this. And it looks tiny and it looks like it's irrelevant. But in reality, this becomes a major issue for this particular patient. So that's patient one. When we look at patient two was referred about 1 month post-injury, and all of a sudden we see patient two's initial x-rays looked okay, and these ones look horrible. So if we take a look on the lateral view, now we start to see fracture dislocation of the radiocapitellar joint. We start to see some fragmentation that's become evident in the anterior radial head, and a slight ossification along the periosteum of that neck. All right, so again, not a great injury, and looking more like a missed Salter-Harris 4 radial head intraarticular fracture. And so when we look back at this particular patient's x-rays, we can see a large fat pad sign. And again, similar to patient one, we really scrutinize, we can start to see some tiny avulsion fractures, okay? So here's some evidence of the Salter-Harris 4 fracture here with that anterior tiny avulsion fractures of the radial head neck junction. And in this circumstance, we might actually see a tiny little cornoid tip fracture, okay? So that's patient number two. Patient number three, so now we're kind of learning a little bit. So patient number one, remember, was referred only after 3 years, patient number two after 6 weeks. Now we see patient number three, now referred at 2 weeks. Again, similar to patient number two, we start to see some fracture fragmentation coming out, some periosteal ossification, and again, this posterior subluxation of the radiocapitellar joint. And then if we do scrutinize the initial x-ray, we may be able to see, okay, well, there's a hint potentially on this AP view of a Salter-Harris 3 intraarticular radial head fracture. Oops. And, more astutely, we can take a look at this patient's MRI, which was obtained at this time, and we can see, yes, there is subluxation of the joint. Yes, there's an intraarticular fracture with displacement of this intraarticular fragment, and we see something interposed in the joint. Okay, so another fracture missed on the initial x-rays. Patient number four, now we're learning from our mistakes. So when we saw this patient, this was the initial x-rays, we did notice, well, it looks like there's that anterior fleck. There looks like there's a fracture line, perhaps indicating a Salter-Harris 4 fracture. So we obtained an urgent MRI at presentation. And lo and behold, yeah, we do discover an intraarticular radial head fracture, Salter-Harris 4, with some displacement both on the coronal as well as on the axial plane. So a large intraarticular fracture. Lastly, patient number 5, we continue to learn from our mistakes. This patient's slightly older, more skeletally mature at 14 years old here. And so we order an urgent CT scan. And we can kind of see there's something going on this side. It doesn't look too evident on the lateral views.
Something happened in the purpose that they are solved.
Something happened to the.
What happens here is.
Oh, no, we are good.
We're good? Okay.
Yeah.
Okay, perfect. And so that brings us to the trash lesion, and sort of coined by James Kasser, and this really seminal paper brought forward by Dr. Waters out of Boston Children's. So the radiographic appearance seemed harmless. And these lesions really they represent pediatric lesions, typically in quite younger patients, roughly between 10 and 14 years old. They represent large osteochondral fractures, which are unrecognized on initial radiographs. And they pose a significant diagnostic dilemma. As you can see, if you are quickly in a fracture clinic of 50 patients, you might not be able to pick this up as you're running quickly through, because alignment looks fairly good on the initial x-rays. But if missed, as you can see from a few of these patients, there are dire consequences. And so from this article, they outline a number of these trash lesions. Sorry, excuse me. But what I'm really going to focus on, because I think we're, as pediatric surgeons, orthopedic surgeons, we get pretty good at identifying these remainder of these types of fracture patterns because they're more common. But I'm really going to focus on this radial head anterior compression fracture. And if missed, has very significant consequences of progressive radiocapitellar subluxation. So it's a JPO article, a great article to refer to. So the biggest thing just to start out with is, the radiographs for pediatric patients can be challenging to read. And so knowing these growth centers, their appearance, and also the order of their ossification becomes quite important. If we look at patient number 1 here, we start to see, okay, these centers are appropriate for I think he was an 11-year-old. All right, everything looks pretty good. But is this typical? Yeah, actually, at 11 years old, you start to have the ossification center of the lateral epicondyle becoming present. And so these are things that we do have to know in order to read radiographs. So that's step number 1. And then as a result, the essential lesion of the intra-articular radial head compression fracture can result in these things. And we see this. This is patient number 1, their MRI taken. And this really, so this is by Goldfarb and colleagues out of WashU. So they described this trash lesion from emanating from the missed radial head fracture. And what you see, which was very evident on this particular patient, is radial head enlargement. We see posterior lateral subluxation of the radiocapitellar joint. We see severe radiocapitellar joint arthrosis and premature physeal arrest. So these important dire consequences now. So this is the essential lesion. And so these result in certain level of instability and settling of the capitellum into that kind of die punch, and into this kind of subluxated position, causing functional limitations, primarily pain, and deficits in range of motion. So if we turn to patient number 1, we actually performed a radial head excision. So we went in there, and this patient has now a deformed, enlarged, subluxated joint, grade 4 radiocapitellar arthrosis, and severe pain. And so there's not really another choice for this child now. And so we performed this. But when we look at what other options are there many? So we can perform a radial head excision. Can we perform a radial head arthroplasty in a pediatric patient, a metallic arthroplasty? And then there's the third option of interposition arthroplasties. So, I think most people we'll consider a pedicled anconeus flap pulled in, or allograft options such as Achilles or tensor fascia lata. And so this is another one of my patients here, severe radiocapitellar joint arthritis. And, we do have to think about, if we are going to think about radial head arthroplasty or metallic arthroplasty, well, if we look at the capitellum, there's often this kissing lesion adjacent. So the capitellum does not remain untouched in this. And so this can pose some concern for joint replacement or osteochondral allografts. So there are some concerns with radial head excisions, and this is more borne out of biomechanics studies as well as looking at adult studies. And there can be, or this can introduce significant lateral column instability. So this is a very nice article actually out of where I did my fellowship. Jim Johnson is an engineer there. So him and Graham King looked at the effect of cutting out a radial head on the biomechanics. And what happens is that you have a loss of the tensioning cam effect. And as a result, sometimes we can see this with chronic montages as well, where that radial head is not in alignment and we just don't have that lateral strut. So we see progressive cubital valgus. And because of that cubital valgus, you have kind of pivoting back and forth in the coronal plane on that medial ulnar humeral joint. And as a result, you have increased ulnar humeral joint contact stress, and you can also have stump impingement. And so there are some significant consequences, mainly born out of some biomechanical studies, but we do have to pay attention to these, especially in very young patients. The other concern with regards to radial head excisions, especially in light of traumatic injuries where you might be faced with injury throughout the interosseous membrane or other supporting soft tissue structures, is axial instability. And so you can see proximal migration of the radius in two circumstances in pediatric population. One, because of potentially interference or injury to the interosseous membrane or the soft tissue structures. And two, because of continued growth of the ulna distally, where it does appear like the radius is actually proximally migrating, but there is a growth differential between the ulna and the radius. And this can result in both circumstances in ulnar positive variance and subsequent ulnar-sided wrist pain from ulnar impaction syndrome. And so here's an example. Now this is this patient had an osteochondral lesion on his radial head and PRUJ. And so this is a patient where I cut out the radial head because he was having quite significant pain. And lo and behold, we're stuck with this patient who in the operation has very significant instability already after his radial head is excised. And you can have the circumstance where the radial head really is a secondary stabilizer. The LUCL is the main primary stabilizer of the lateral side of the elbow. And when you might have a stretched out LUCL or an incompetent LUCL, then that radial head is surely very important. And so you want to make sure that your patient is not faced with any incompetencies of the ligaments before you perform this. Otherwise, you're going to be faced with a challenge here. And then if this develops over the course of time, you can see now, especially from that middle view, you've got impingement on that ulnar humeral joint. And that's where, where the development of medial-sided arthritis can result, okay? So consequences of performing a radial head excision. There's very little in the literature regarding radial head excisions in a post-traumatic status for the pediatric population. In fact, they're very, very small case series. But these two, despite having the low number of patients, they demonstrate very clear results that are identical. And so immediately we see in the short term And then in the short to midterm, we see good range of motion post-operative. So essentially removing that radial head permits both flexion extension as well as pronosupination that was blocked. We do see complications though. Whether or not that they're symptomatic, we see very similar ones between these two. So progressive cubital valgus, which I just demonstrated in the previous slide, as well as ulnar positivity. And in this sort of midterm outcomes causing ulnar-sided wrist pain, and of the about 50% of the patients did require subsequent ulnar shortening osteotomy to address this. So it does have some consequence even in the midterm for pediatric patients. And so at Cincinnati, when I was there, I did a retrospective chart review of 13 children who underwent a radial head excision for post-traumatic severe radiocapitellar joint arthrosis. And out of these 13, the vast majority, so about 3/4 of them, had missed radial head fractures. All of them had severe radial head and or capitellar arthrosis, and they all underwent a radial head excision for this post-traumatic arthrosis. And what we found was that so this is very short term, so median 4 months follow-up. The mean age at radial head excision was nearly 14 years old. What we demonstrated was excellent short-term results. These kids' Mayo Albert Performance Score was really good early on. Motion was significantly improved, primarily in extension, flexion, and pronation. Supination approached significant improvement, but was not statistically demonstrated. But what I really want you to take away from this is all 13 of these patients had ulnar positive variants at their final follow-up. And which quite striking is that the median ulnar positive variance was 5.3 millimeters, and the mean 5.5 millimeters. This is significant. None of them described any pain associated at the time of their short-term follow-up, but in a very short period of time, they all demonstrated ulnar positive variants. And although not significant, there was a weak negative association between age at the time of radial head excision and ulnar positive variants, meaning the younger the patient was at the time of radial head excision, the more likely they were going to have a more significant ulnar positive variance, okay? But very weak association, right? So here's an example of a patient who over the course of time, as they became skeletally mature, demonstrated a progressive ulnar positive variance in this cohort. And this patient 5 years out, this is extremely significant. So 10.9 millimeters ulnar positive. So this is going to clearly be an issue for him. Yes, he remains asymptomatic now, and that might be part and parcel is that he wants to go into the military, and he can't have a medical issue, obviously, of his wrist. Okay, so ulnar positive variance, it's a real thing. It occurs very quickly. So in these patients, the biggest thing is that you've got to warn the patients about the possibility of ulnar-sided pain because of proximal radial migration, possibly requiring a subsequent procedure like an ulnar shortening osteotomy in the future. So what about a radial head metallic arthroplasty? Well, again, very, very little in the literature about this in a pediatric population. And so there remains quite significant concerns with regards to the metallic arthroplasty in kids. And one is a size mismatch following growth, right? And so the radiocapitellar joint not only requires stability from an intact LUCL and the radial head, it also requires a kind of a compression type relationship between the capitellum and the radial head, compression concavity, really to help maintain that stability there. And so if you have a size mismatch, they grow and it's too small, then you actually might have inherent instability that arises. The second concern is implant survival and loosening. We really don't know if there's any long-term survival in this, or whether or not, because they're kids, they will likely need another arthroplasty soon down the line. We also worry about progressive capitellar erosion, particularly in patients who might already have the onset of arthrosis of the capitellum due to that kissing lesion. And then also, we don't really know what recommended restrictions would be in a young patient who has this type of arthroplasty. So a few concerns here. There's this one case report in the literature of 5 patients. Mean follow-up of 8 years. And what's, out of these patients, 3 of them, so more than half, had pain with activity at final follow-up, although they did not demonstrate any implant loosening. So it's not perfect by any means. But again, only 5 patients written up in the current literature. Well, that brings us to interposition arthroplasty. So say we we have to cut out that radial head. Should we be also doing a concurrent interposition arthroplasty? And so there's a couple options that I mentioned before: Achilles, allograft. I use a tensor fascia lata that I fold up, and some people use this pedicled anconeus flap, and you can kind of see these photos here of the anconeus being raised and then pulled into the joint. And the reason for adding this, people surmise that it's useful to address capitellar or PRUJ articular damage. It can potentially reduce the ulnar humeral joint contact forces. So we saw, that varus valgus motion with the radial head excision. And potentially long-term, it could minimize that medial-sided ulnar humeral joint arthritis. And potentially it could maybe act as a load-bearing surface for that lateral column. But again, very limited data on the pediatric patient or young patients. And what we do see from adult literature or young adult literature, there is a high complication rate. So despite putting this, either an allograft or this pedicled flap in there, there's still a high rate of post-traumatic arthrosis that forms. So again, not perfect. And reoperation rates are quite high at 25%, again, in an adult population. My preference is this. This is an Israeli technique article. I like this as my interposition. Here they use Achilles. I fold up fascia lata into kind of this square and place this into the interface, and either with an anchor, or if there's still some annular ligament in that area, you can anchor it to that soft tissue. And then you bring the remnants of the annular ligament around and you sew this to that to hold it in place. And this just, whether or not that adds much, but it may provide a little bit of a cushion. And if you've got proximal radial migration or potentially even radial head overgrowth, then this might buffer this impaction from impact on the capitellum, and who knows, potentially has an effect on minimizing stump instability or stump impingement. Again, a really small case series in this pediatric literature of only 4 patients with the radial head excision plus the interposition. They still saw improvement in range of motion as well as patient-reported outcome measures. But again, it does not stop proximal radial migration. It's 75%. So 3 of these patients still demonstrated some level of proximal radial migration and ulnar positivity, where one of them had to have a subsequent ulnar shortening osteotomy. Okay. So again, not a perfect option. So moving on to patient number 2. So remember, this patient was 6 weeks delayed. And so we opted to perform a lateral approach to the elbow. I prefer an ECU split here, and then extend this into a column approach to avoid PIN as well as avoid the LUCL. And what we found is that it was already healing. And so we had to almost osteotomize this, trying to maintain the periosteal sleeve intact. And then able to restore that concavity of the radial head, and secure this with, I think these are 1.5 millimeter modular hand screws. But as you can see, there is a gap there. So this is also a little bit nerve-wracking as to, all right, well, what's the risk of problems like AVN, malunion, resorption, and is there a risk to early range of motion when we don't have quite this support? This patient surprisingly has done fairly well early post-operative, has minimal pain. Flexion extension and pronosupination, though, are affected. So, this is only 3 months. I probably should update this to see what the range of motion is now. But still, open reduction internal fixation, we know, has a higher risk of elbow stiffness, which we very obviously see in this patient. We go to patient number 3. Again, this was a delayed ORIF after 2 weeks. And this was where there was some subluxation, posterior subluxation of the joint. And luckily, unlike the last patient, we were able to clean out the fracture site and get a very nice reduction. Again, same approach, the lateral column into the ECU split, and then using these modular hand screws to perform the fixation, again to restore that nice concavity. I prefer these types of screws typically over buried headless compression screws, especially in young patients, because they headless compression screws are nice and strong. They actually might provide too much compression in these highly cartilaginous parts of the pediatric elbow, and actually might cause collapse a little bit of the articular surface. So that's why I prefer to utilize these screws. Patient number 3, 1.5 year follow-up. Again, x-ray is not perfect, right? So, but alignment seems to be okay. Has some intermittent pain, no instability though, some crepitus, has excellent range of motion, surprisingly. And so we have some winners after these, but still we can see there looks like there's some arthritic changes, and we don't know if this intermittent pain is going to be a problem in a very near future for quite a young patient. Remember, that patient was only 6 years old. This was patient number 4, where we got that early MRI. And so on the day that this patient came to our hospital, and we can note that there's a 2 millimeter gap, both in the axial view as well of a 2 millimeter step off. And so trying to reduce that, and then again, put those modular screws in to fixate that. And this patient started very early range of motion, and even at 6 weeks, excellent range of motion. Okay, so these patients that you can you think have a small avulsion fracture, you get an MRI, you treat them very quickly, stable construct, getting them moving right away, then they can benefit fairly significantly from the fixation and not be as significantly impaired with regards to elbow stiffness. So we do see a little bit of a difference, quite a big difference between patient 4 and even patient 2 and 3 that came in a delayed manner. And so this is some radial head ORIF unpublished data that myself, the team from Cincinnati Children's, Boston Children's, and CHOP put together. And it's a retrospective review between 3 hospitals. And this is looking at 36 patients, 36 intra-articular radial head fractures in 35 patients. And the primary outcome was just looking at successful radiographic healing. And out of this cohort of patients, 12 of them were treated non-operatively. And what's very interesting is that there was only from a radiographic perspective, 50% success rate. And all 50% of those that went on to successful radiographic healing had under 1.5 millimeters of initial displacement seen on either X-ray, CT scan, or an MRI. The other 50% went on to non-union and required an eventual radial head excision. Okay, so these are non-operative patients. There's 24 patients treated initially with ORIF. 88% of those patients had successful radiographic healing. And there were some complications. One developed avascular necrosis. 2 who underwent a delayed open reduction internal fixation. So after 7 months, this failed, and they eventually went on to a radial head excision. This study really demonstrates that early identification, early treatment of these patients, particularly those who have displacement over 1.5 millimeters, do well with a early open reduction and internal fixation with regards to radiographic healing. Whereas those, a lot of these up to 50% in our cohort treated non-operatively were unsuccessful. Patient number 5, this is the 14-year-old, skeletally mature. We opted to get a CT scan. And what we found was this, a fairly significant radial head fracture with significant displacement and a flipped fragment that's basically interposed in the radiocapitellar joint and some level of fragmentation adjacent to the physis, or the physeal scar, I should say. Patient number 5 shows us that things may not, the world ain't all sunshine and rainbows as per Rocky. And what we found in the operation, so this is intraoperative view of what we see. And so with pronosupination, we see this unstable radiocapitellar joint. So in pronation, it's going anterior. So we see this translation in the sagittal view, and there's some level of instability as well. And what we did find is that essentially there is a large loose osteochondral fragment. So really not a good thing for this patient. We fixed this. It looks, pretty good intraoperatively. Again, fixed it with those modular hand screws. But then, once we fix it and it looks fairly anatomic, we take this through a range of motion. And here's the live fluoro. So with supination and pronation. Okay. So this patient is not just a radial head intra-articular fracture. You can see 2 things on this. Most obviously, the anterior dislocation of the radiocapitellar joint with pronation. We can also see some ulnar humeral gapping. Okay, and so this patient, there's a level of instability as well with this injury. And so that brings us to the role of soft tissue stabilizers on the PRUJ. So something we should think about as well, especially in these higher energy injuries with quite significant displacement of intra-articular fractures, where the soft tissue surrounding may be impacted and may have to be addressed in your initial operation. And so this is a really interesting article. So this is a Japanese article that looked at cadaveric sectioning of the PRUJ stabilizers, namely the annular ligament, the quadrate ligament, and the proximal interosseous membrane. And they sectioned them in order. And so they first sectioned the annular ligament. And what they found is that in a neutral position forearm rotation, there was only lateral displacement of the radial head. Okay. And when they subsequently sectioned the quadrate ligament, they showed that there was posterior displacement of the radial head, indicating that the quadrate ligament, so this is it right here, plays a role in stabilizing the radial head from posterior subluxation. And it's really only until they sectioned annular ligament plus quadrate ligament plus the proximal half of the interosseous membrane that they found the addition of significant anterior displacement, regardless of forearm position. Okay, and so there needs to be a fairly significant soft tissue envelope disturbance for this to happen in the setting of, maybe an isolated radial head dislocation, or potentially a fracture dislocation, like in this case. And so this patient has not gone on to a good result at 7 months post-operative, so they're not all winners here. All right, and so we see very, quite significant limitations at 7 months out of especially flexion and extension. Pronosupination is an acceptable functional arc. This one, I used these headless compression screws to try out a new device that was being tested in our hospital. So that's why these are used instead of the other. Maybe I should have stuck with my regular modular hand screws. But we see a collapse of the radial head in that area where that loose osteochondral fragment was fixated. We also see heterotopic ossification, or ossification potentially along a periosteal sleeve, or where we may have expected or seen some level of soft tissue disturbance. So in this patient, looking at the CT scan, it really does show some collapse and that loss of the compressive concavity of the radial head. And then perhaps indicating that there is a larger soft tissue envelope injury. So this patient's actually awaiting an MRI to look at the quality of that head. I wonder if it's AVN. All right, so that brings us to the complications with proximal radial open reduction and internal fixation. But in general, with proximal radius fractures, intra-articular and extra-articular, the biggest thing with open reduction is that stiffness is a huge risk, and 30%, maybe even greater with ORIF experience this. There's an increased rate of AVN with open reduction and internal fixation of 1%. And this increases with the level of displacement. Heterotopic ossification, like we saw in patient number 5, is about 2%. Synostosis at the proximal radial ulnar joint, 1%. And physial arrest, 1.5%. So things to consider and to discuss with patients, particularly patients who have highly displaced fractures that are irreducible and require open reduction. And so, there's a number of lessons learned or questions, potentially more, that need answers. And so from, my experience here, number one thing, reading x-rays, just familiarize yourself with the normal patterns of secondary ossification center in the skeletally immature patient. You want to know what's supposed to be there and what's not supposed to be there. If you see a tiny fleck of bone on an x-ray, this does not equate to a tiny injury, okay? Minor joint malalignment is not a minor issue. When you have a higher impact injury, as you saw, the majority of these patients, except for that 6-year-old girl, were all high-level sporting injuries. When you have massive swelling and crepitus with normal radiographs or innocuous radiographs, then you should have a higher clinical suspicion of a potential trash lesion. And that's where I would say, please consider an MRI to evaluate for osteochondral lesions. For these radial head fractures, based on our multi-center retrospective cohort study, early open reduction and internal fixation should be considered, particularly if your radial head fracture is more than 1.5 millimeters displaced. But remember, you have to, it's much better if it's fixed early, and you also do have to discuss the complications that can arise, primarily stiffness, but other ones such as AVN, HO, synostosis, physeal growth disturbance, all about 1 to 2%. And then radial head excision. Our own study and literature suggests there's excellent short-term to mid-term results in very low number of patients. We do not know the long-term consequences. And we also do not know if concurrent interposition arthroplasty may minimize some of these long-term consequences of instability, of ulnar humeral joint impingement, of proximal radial migration, or at least symptomatic proximal radial migration at the elbow joint. And so these are all things to consider or questions that need to be answered. All right, thank you very much for the opportunity to speak, and I'm happy to take any questions or any discussion.
So that was a great talk, fairly, comprehensive. It raised questions and it answered at the same time. One thing is for the trainees and fellows, of course, your conclusion slide says when one should suspect the trash lesion and when to get an MRI, extensive swelling. And so one thing I teach our fellows to always take a contralateral X-ray when you have doubt. And if you find anything abnormal, that mounts to investigation. So what is your message that when you want to go for additional imaging?
Yeah, so
Just to reiterate, what you said.
Absolutely, this is the hardest part about these trash lesions. And so my biggest message to, especially to my trainees who are seeing patients in the emergency room in fracture clinic, are these patients who have higher energy injuries. They have massive swelling at the elbow joint. And their radiographs really are innocuous. Like it's almost disturbing that you can't find a fracture based on the level of energy and the amount of swelling. That is when I say, please consider some level of advanced imaging and considering an MRI for those patients who are quite skeletally immature. You saw in the last patient number 5, he was reaching skeletal maturity, and we were able to gain the information we needed by a CT scan. But the MRI for these patients who are, 10 to 13 years old, I think is quite important to consider. Yeah, and so for me, it's higher level energy, a very large swelling, and just a very an X-ray that just doesn't seem to match. And the areas where I really urge you to focus your attention on is that anterior radial head. Look specifically there, blow up that X-ray on that lateral, make sure you got a good view and see if there's any little fleck of bone there. Because honestly, there's only been one MRI that I've gotten that had that fleck, and it did not have a radial head fracture. Okay, so I think that in itself is just look for that, because I do think we're very good in general at picking up these other trash lesions listed in that article. We're good at picking up medial epicondyle incarcerated fractures. We're good at picking up lateral condyle fractures with a little sliver that we can see in those really young patients. We know what to look for transphyseal humeral fractures in very young patients. But it's these radial head fractures which are, I think, very hard to pick up.
That's correct. And another question was, in your retrospective study, did you find any relation between the age of patient when the radial head excision was done? So what I mean to ask is, if we end up excising the radial head fairly early, should we couple it with enconius interposition arthroplasty compared to an older adolescent where there is less potential of proximal migration? So, I mean, of course, this number was very less, but could you conclude on that point?
You know, I feel so the literature unfortunately does not guide us. We have 4 patients in that study, and 3 out of the 4 still demonstrated radiographic proximal migration. I always do an interposition arthroplasty for every radial head excision I'm doing in kids. You know, whether that may just make me feel better for cutting out, you know, the lateral column of the elbow, but I do, you know, I do think there is some level of cushioning of that joint. You know, especially because there are other risks, not just proximal radial migration, but there are risks of radial head overgrowth there. There are risks of stump impingement. And I think having that cap, you can use Achilles, is very thick. So I've used Achilles once and it was really, really thick. So it was very hard to get that sutured in the way that that Israeli technique shows. I like the fascia lata, and I usually get a very long piece so I can fold it. I'm gonna have a little bit more control of where I'm putting it. Also, just basically like a mushroom cap on top of that radial head. And I think that acts, you know, similar to very meticulously closing up periosteum. But I do add that in. You know, some people have raised, well, what do you think about performing concurrent interosseous membrane reconstruction of some sort? And, you know, I don't think that this is necessary when we're not convinced there's a larger soft tissue envelope injury, primarily of the interosseous membrane. If we don't think that that's the case, then really this proximal radial migration is due to growth, differential growth, I think. So I don't think it's going to add any stability to the elbow in terms of progressive cubital valgus. I don't think it's going to prevent proximal radial migration, but it may prevent the impingement effects proximally. And that's why I do it.
Yeah, so there's a question from one of our colleagues, Dr. Suma Raju. What are your indications for radial head excision and or replacement today? So I think she mentioned this, but can you reiterate this?
Absolutely. So for radial head excision, it's going to be upfront like that, similar to that slide that I presented about the essential lesion. But really, in general, it's patients with severe arthrosis of the radiocapitellar joint. So not just the radial head, but also the capitellum. Okay, so when you have enlargement, you have growth disturbance, you have subluxation of the joint, it's really now there is no way to intervene with, say, a large osteochondral fragment or some level of osteotomy or reconstruction. I don't think that's the case, especially when these kids are presenting with pain and lack of range of motion, and they're really not going to do well with anything but at this point in time. Replacement, I have done one replacement, and that was for progressive cubital valgus in that kid that I showed. And I'm not really too happy with that, but that may be from a different perspective because there was this patient had osteochondral, I'm sorry, not had some level of very minor MHE, and so they had some changes at the PRUJ. So I was not happy that that radial head was sitting congruently in the PRUJ. So it works. It works to hold to minimize the instability, but it's not perfect in this circumstance. And I think you can consider a radial head replacement, a metallic replacement, in an older kid nearing skeletal maturity who has no capitellar arthrosis. So I think there has to be, I think there are very significant limitations. And that head, if it's already starting to subluxate or become unstable, then I don't think that an metallic arthroplasty is a good idea. So you have to have a stable elbow as well. Okay.
Another question from Tashween. After radial excision, if there is an ulnar positive variance, then what would be the management? So you mentioned that as well.
Yeah, that's this is a really good question. I typically will treat this when they become symptomatic, or largely when they're done growing. So hopefully that corresponds, and then they become symptomatic with growth stopping, and so then I'll do an ulnar shortening osteotomy in that circumstance. But I think I would tend to try and wait until skeletal maturity, so there's going to be no change. Obviously, if that's the case, if they're skeletally immature, then I would shorten them, and then also potentially do an epiphysiodesis of the
Epiphysiodesis.
yeah.
Yeah, so the key thing is to follow these patients up, because many a times the early results of excision is good and they will have the pain is not there and they are moving well, but you keep them in follow-up, and if they have symptoms of distal radial nerve joint, and then you have to consider this treatment.
Yeah.
Chinmay has one question. Chinmay, yeah.
Yes, yes, sir. Dr. Chan, do you think approaching with a dual approach like interposition arthroplasty plus distal radius ulnar pinning will eventually help to prevent the proximal migration of radius? I mean, keeping them in 4 weeks and then start slowly mobilizing after removing the pin from distal radial ulnar?
Yeah, I'm not sure. Because I think that this is more of a growth discrepancy.
Mm-hmm.
We're not really affecting the distal ulnar growth by pinning the PRUJ. I would probably err away from that because I would be more concerned about causing even more significant stiffness through pronosupination. I think we do see flexion extension deficits. Pronosupination can come back. But I would be really nervous to interfere further with their pronosupination in patients who are already at risk with this injury and with subsequent ORIF.
Okay, sure. Thank
Yeah,
you.
so that's what we have seen, Chinmay. The in brachial plexus palsy, when this radial head is already dislocated and convex, and there is supination deformity. If we have done pronation osteotomy, as there is no proximal ankle, it will go back into supination. In those cases, we can tend to fuse the distal radial ulnar joint or put a wire or a screw in a mid-prone position, and that maintains. So putting wires may increase the stiffness, which we have feared of.
Okay.
All these patients would need open reduction, and we know that for radial neck fractures, we try to avoid open reductions because there are high chance of AVN. So what precautions we should keep in mind when we are dealing with opening these radial heads to prevent AVNs?
Very excellent question. And so, the risks with opening this. So not only are the anatomic risks of PIN in the front and LUCL in the posterior aspect of the lateral column. The things that are very specific to the pediatric population is the blood supply and the periosteum. And the annular ligament, really. And so when I go in, my interval is the EDC split. I love this interval. It is, you really can be reassured to avoid critical structures on both the anterior and posterior aspect of your interval, meaning the PIN and the LUCL. And go up the column with my approach so it can really open up the anterior capsule. But I stay anterior. So I stay anterior to the mid-sagittal plane for two reasons. One, the posterior blood supply, and two, I don't want to get into the origin of the LUCL. But I would not be shy about extending up the column in order to lift that anterior capsule up so you can really get across and see, get debris out of the joint, look at the PRUJ, fish out any loose bodies, and be able to get a good visualization of your radial head. And so those are the few things that I would recommend. Now, we know that the annular ligament anatomically, when we do our reconstruction of the annular ligament, it is not anatomic. It's around the neck. But remember, the annular ligament in reality is a structure that sits around the head. So you're going to have to cut through it or through part of it. And so what I do before I cut it is I just take large sutures and I
Big
tag.
sutures.
Have tagging sutures. Okay, so and I have those in place so I never lose sight of those ends because I'm going to repair that afterwards. But I do cut about halfway down in order to open up and visualize the radial head. I try not to go any further than the lip, kind of the distal lip of the radial head, unless it's a large Salter Harris 4, something that does require some level of visualization at the neck, but I try not to do any significant dissection subperiostally down the neck.
Fair. So that was it's 9 o'clock, and you answered most of the questions. If we have further more, we will communicate through email.
Perfect.
I'm pretty sure that most of us are benefited with this talk, and it will increase their level of suspicion when, yeah. So it's an email, so those who have questions can communicate personally. Thanks, Andrea, for your time, and we all enjoyed this talk, I'm sure. I
Yeah,
learned
it's
a
my
lot.
pleasure.
Thank you so
Yeah.
much, Dr. Chan.
Thanks, Chinmay,
Okay.
from
Thank you.
coordinating this. And maybe next week, I'm going to talk about radial neck fractures and our technique of production. And over a period of years, we have started extending our close reduction technique in difficult radial necks, where we would not think of anything else but to operate upon them. We could treat few of them without surgery. So you can join if you have time. We'll share
Send me
the,
a link. I would love to hear your techniques
yeah,
because those are the new bane of many of our existences when it comes to the pediatric elbow.
sure. Right
Sure.
on. Have a good day. Thank you very much.
Thank you.
Fantastic. Thanks for
Take
having
care.
me. Thanks,
Thank
everyone.
you.
Thank you.
Thank you.
Bye.